Hello, everyone. Welcome to today's webinar, and thank you for joining us today. I'm Manny Robitaille. I'm an assistant professor at the University of Ottawa and hold the Commissioner Ottawa Research Chair with the Centre of Excellence in Frailty-Informed Care at Pearly Health. Today's presentation is entitled Recipe for Health, a Multidisciplinary Approach in Long-Term Care Homes. Following today's presentation, there will be some time for questions. You can ask your questions by writing them in the Q&A box at the bottom of your screen. We will do our best to go through all of your questions. We also ask that you take a minute at the end of the webinar to complete a short survey that will appear on your screen when you exit the webinar. Today's webinar will be recorded and will be made available shortly after the webinar on the Pearly Health CoE website. It is my absolute pleasure to introduce someone that I have had the pleasure to work with closely, and that even as an early career researcher has accomplished so much. Dr. Suey Young is a postdoctoral fellow in the Interdisciplinary School of Health Sciences at the University of Ottawa and at the Centre of Excellence in Frailty-Informed Care at Pearly Health. She completed her PhD at the Vrije Universiteit Amsterdam in 2020, where her dissertation examined strategies to assess and optimize muscle health in geriatric outpatients. Following her PhD, Suey completed a postdoctoral research position in the Faculty of Medicine of the Chinese University of Hong Kong, where she focused on the role of nutrition in promoting healthy aging among community-dwelling older adults. Suey's current research aims to improve the health and well-being of older adults living in long-term care homes. Please welcome Dr. Suey Young.
Hi, everyone. Thank you for joining our webinar today. So today in the webinar, I will talk about some literature related to interventions in long-term care homes. I will also introduce you on a very new and exciting project happening at Pearly Health and share with you some preliminary results of this program. So before we plan any programs or services for our residents, we have to understand their demographic and their healthcare needs. So this paper investigates the annual changes in socio-demographic characteristics, morbidities, and functional status of newly admitted nursing home residents in Ontario over a 16-year period. And they find that the characteristic of incoming residents have changed. In specific, more residents are entering at an age of 85 years and above, and there was an increase in proportion with residents who have 7 or more morbidities, with 9 or more medications, and extensive limitations in their activity of daily living. Indeed, those characteristics, such as advancing age and morbidities, put the residents at higher risk of different health outcomes. For example, malnutrition, weight loss, or reduced food intake. The residents may not like the food served, and they may need extra feeding assistance, or they lose appetite because of their medications or their chronic diseases. Second problem is sarcopenia, which is low muscle mass and low muscle strength or poor physical performance. And it is partly due to malnutrition and also a lack of physical activity. And then there are some psychological problems which are quite prevalent in nursing home settings because residents are isolated and they don't have many opportunity to connect with their family or friends. And this results in more mental health problems, which worsen their cognitive function. And all this actually reduce their quality of life, increase their risk of falls, contributes to frailty, and also increase the burden of the care partners. And fortunately, there are some interventions that have been proven to be effective for long-term care home residents. For example, music therapy, like some sections, they sing familiar songs to prompt their cognition. They may write simple songs to express their emotions. They play instruments to release their stress, or just listening to music to explore their feelings. And music therapy has been shown to increase their socialization or communication, reduce depression, and also improve the cognitive function of those living with Alzheimer's disease. Another type of therapy that is common is politicultural therapy, which is contact with the nature. So there are two types. One is active engagement. So residents do some hands-on gardening activity. And the other type is passive engagement. So just do a garden touring. And during the process of politicultural therapy, the appearance of the plants, the color or the smell of the plants provide a multi-sensory stimulation. And it has been shown that those who have politicultural therapy, they improve in their quality of life, reduce their anxiety, depression, and also improve in cognitive function. And then art activities like painting, drawing, photography. There's a scoping review showing that it contributes to well-being because it can improve their social relationship. Another type is intergenerational program. So it's an organized activity for preschool children, school-age children, teenagers, and the older adults. So it provides social engagement for them to interact with each other. And the contents of intergenerational program can be diverse. They can talk about music, talk about art, share information. It depends on what the older adults want to do. And intergeneration program also has been proven to increase the pressure level of the residents. In terms of cognitive exercise, cognitive stimulation programs has lots of evidence around that. So it emphasizes sensory stimulation and provides an environment that forms individual engagement in a range of activities and discussions. And cognitive stimulation therapy has been shown to improve cognitive function, social interaction, and quality of life of people living with dementia. And also there are some evidence that CST can elevate the depression level of people living with dementia. With the advancement in technology, there are some technology-based programs like virtual reality. So the players are able to interact with the game scenario while they are doing exercise, and it provides them an experience to actually do the exercise and also stimulate their sensory function, cognitive function, and motor function. And then the traditional exercise program, it has evidence showing that it improves the physical performance of the residents and is beneficial for improving the cognitive function. And finally, nutritional intervention. So there are different types of nutritional intervention that helps to optimize the nutrition of the residents. For example, feeding assistance during mealtime, nutrition education for residents or staff, provide more nutritional snacks or nutritional supplements, or changing the dining experience, like listening to music while eating a meal. And also nutritional intervention has been shown to improve physical function. So it's great to know that there are many great programs available and has been shown to be effective for residents. But very often residents join programs from only one or two disciplines. So it may be because not all programs are available in long-term care homes because of a lack of resources, or it may be because the residents are not interested in other programs, or they are not aware of the benefits of joining different types of programs. But in fact, the effects from different programs may interact with each other and provide greater health benefits. And so we want to take the advantage of this fact when planning a multidisciplinary program, in which case 1 + 1 may be greater than 2. So we call this additive effect or synergistic effects. Take this article as an example. This one investigates the combined intervention and see whether it has greater benefits than single intervention alone. So compared to the control group, the combined intervention group with both physical activity and cognitive activity showed larger gains in cognition. Compared with those who only have physical activity intervention, the combined intervention group showed greater cognitive improvement. And there's no significant difference when comparing with cognitive activity alone. Another example about nutrition and physical activity. So compared to the studies with only physical activity intervention, those with both nutritional supplements and physical activity intervention showed greater improvement in lower limb muscle strength. Similarly, compared to studies that have only nutritional intervention, the combined intervention studies showed greater improvement in physical performance and also bone mineral density. So we can see the additive effect when we combine different interventions in the program. So given these additive effects, some multidisciplinary programs have been designed for community dwelling older adults. For example, in Hong Kong, 12-week program of exercise, cognitive training, and board game activities has been shown to improve their physical function, cognitive function, and self-rated health, and also reduce their frailty score. Similarly, program in Singapore and Australia, the multidisciplinary program compared with control group is improved their physical function and reduce their frailty scale. So this is a scoping review of long-term care intervention around the world. So what they find is that there are 15 studies that adopt a multidisciplinary approach. However, when I look at these papers in details, actually only 1 out of 15 studies were conducted in long-term care home. The others were conducted in long-term home and community-based services. So those other studies are in the community settings. So what we already know from the literature is that multidisciplinary program can be effective to promote health and well-being of long-term care residents. But due to some potential challenges in long-term care home, we don't have sufficient evidence for now. So because of this knowledge gap, we would like to assess whether multidisciplinary programs are effective when implemented in real-life conditions. So we designed a program that involves different disciplines and packages nicely for our residents to join. So now I'm going to talk about the research program that we design and pilots at CoE Health. And the study objectives of this research is to evaluate the effectiveness of this multidisciplinary program on health and well-being for our residents and to examine the feasibility and acceptability of this program. In terms of study design, we first screen the residents and do baseline assessment if they are eligible. And then they participate in a 12-week program. And at week 12 and week 24, we do a follow-up assessment. And to answer the first objective, we measure their hand grip strength, body weight, cognitive function, to see if there is any change before and after the program. And we also conduct interview with residents and healthcare professionals to see whether it is feasible and acceptable in long-term care homes. In terms of recruitment, we designed this poster and try to make the eligibility criteria as simple as possible. So you can see we want residents to be able to follow simple instructions so that they can understand the instructors when they are doing exercise. And also we would like them to be able to have a meaningful conversation, because for the cognitive training parts, we would like them to be able to communicate with their group members. So based on what I experienced during the recruitment process, I would suggest that to try to make the eligibility criteria as simple as possible, try to include all the residents that are interested to join. And because I'm a researcher and I'm not familiar with the residents, I don't know how they are doing, so I have to consult with the physiotherapist, the OT, dietitian, nursing staff, US staff, and recreational therapists to really see who may be interested and who have the capacity and meets the eligibility criteria. And their advice is really very helpful. And it is very important to get support from the family, because this is something new to the residents. And if the family member is able to support and encourage the residents to join, the residents will be more willing to join. And before we approach the residents, I would suggest that we already fix the time of the sections so that the residents know that they have other activities at the same time. If they are joining other programs at the same time, and then they may not be able to join all the sections in this program. And also sell this program as something fun, so that the residents don't feel like they are doing something in a research setting and they have to attend the training like in a school. So now I'm going to talk about the components included in this program. The first one is physical exercise. So it's 2 times a week with 45 minutes per section. It's facilitated by our physiotherapist assistant. And we mainly use the chair-based exercise because most of our residents use wheelchair as their primary means of mobility. So we use design chair-based exercise program. And we have multi-component for the exercise program, like stretching. In this photo, you can see they are doing some ankle rotation. They also stretch their arms, their foot, or their back. And then there is a cardiovascular exercise, like they do the pedaling when they are sitting. They also march or do some deep breathing and kicking the ball. And finally, we have the muscle strengthening exercise as shown in this photo. And they are lifting the dumbbells. So this part, we also individualize according to the strength of the residents. Some residents carry 1 pound of the dumbbells, and some residents can carry like 4 to 5 pounds of the dumbbells. So here are some tips when organize the physical exercise components. We will suggest that we understand the exercise habits of our residents. At the very beginning, when I write my proposal, I was quite ambitious and proposed 5 sections a week of exercise. But after consulting with our physiotherapists, we know that it is not feasible. The residents here maximum attend like 2 or 3 times of exercise a week. So we make it twice a week. And we consider a group-based multi-component exercise. Why group-based? Because it provides a social interaction opportunity for residents. It's more fun to do it compared with individual exercise. And try to increase the residents' perceived health benefits of exercise. So not every resident know why they have to do exercise. Some do that because they want to lose weight, but this is not the main purpose. We want the residents to do exercise to train their muscle more often. Otherwise, if they don't use it, they lose the muscle. So we need to let them know what's the health benefits. Some residents have concern of their glucose level, and we can use this as a way to tell them that by doing exercise, it also helps to control your blood glucose level. And provide encouragement during the sessions. This is very important, especially when the residents are able to pass the ball, which they used not able to do so. If they increase their weight in lifting dumbbells, we provide encouragement to them so that they are more motivated to continue. And also share the assessment results. They want to know how's the program help them in terms of their physical function. So if you are able to share their results before and after the program, they are more motivated to continue. And then the second component is cognitive exercise. So it's also 2 times a week with 1 hour per session. We use the cognitive stimulation therapy because we have lots of evidence around this. And we also speak to our OT team at Pearly Health, and they are interested to try this for our residents. So basically, cognitive stimulation therapy is a group therapy program for those with mild to moderate dementia. And the idea is to have a variety of sensory stimulant with a mix of activities, including vision, touch, hearing, taste, and smell, because these can be very limited in long-term care homes. And there is a standardized structure for each section. So first, we play a softball game and then discuss a recent news article, and then followed by the main activities. And for each section, the main activities have different themes. For example, this one, we talk about food. We share with the residents the prices of different food items for now and compare to the past. And then in this section, we talk about using money, like we show them the current notes and coins and how they're different from those in the past. And we also show them the currency from different countries. We discuss about what's the features of different currency. And some residents also share their own collections with the group. So actually this cognitive stimulation therapy is very well received in our residents. And some of the section was also planned by the residents because they want to have an input and they give ideas to our occupational therapists and they help us to plan the activities. And also for those who are not as part of the research project, there are also some residents who would like to join this group. So because there are a variety of cognitive exercise programs, to start with, I would suggest you to speak to the OT team in your homes and get their insights. There are different types of cognitive training, like technology-based or traditional-based. So it doesn't need to be expensive. We gather all the training materials from our daily lives. When organizing the group training, we also recommend to plan the seating arrangement nicely. For example, those who have trouble hearing, we would suggest them to sit closer to the facilitator. And also for those who are a bit shy and not socially active, we also suggest them to sit closer to the facilitator or close to someone who are more socially active so that those residents can also be engaged during the cognitive stimulation therapy. And if possible, offer the refreshment like juice or cookies during the session so that it's like a social event rather than training. And consider the interest and physical or cognitive function of the group members. So for some groups, residents may have different cognitive functions. And for those who has higher function, they may not understand why we are doing this simple task. So in that case, we can explain to them the intention of the activity is not to insult them, but to try to let them think more often and from different perspectives. And for those highly functional residents, we can also ask more challenging questions to them. And we can also invite them to share their knowledge. They feel really proud of themselves when they are able to share their knowledge with others. Allow time for sharing. For cognitive stimulation therapy is focused more on opinion rather than facts. We try to invite all the group members to share their opinions. Sometimes we have to rush a little bit because we are running out of time, but we are learning the process. And the last component is nutrition education. So we work with the dietitian and food service staff. Our idea was to observe their food intake and identify whether their calorie and protein intake are adequate for them, because each resident have different body size and require different nutrition. And so this is what we offer at breakfast, lunch, dinner on one day. And then this is what the residents consumed and left. So the original idea is to see if the intake is not adequate, then we would offer some extra snacks or supplements for them. However, for the first group, because of a lack of funding to purchase extra snacks and supplement for this research project, we only provide nutrition education. So I first observed their intake for 3 days and then provide some healthy eating tips. And for example, how to manage small appetites. And we talk about importance of calorie and protein intake during aging. Protein is important for maintaining their muscle mass, and also what kind of food is high in protein, just to increase their awareness. And also we briefly talk about my diet, which is a combination of Mediterranean and DASH diets that has been shown to be good for our brain health, and is mainly focused on whole grain, like whole wheat bread, porridge, oats, green leafy, nuts, and berries. So I share this knowledge with the residents and advise them whenever this is offered to you in the dining room, please try to choose this item because they are healthy for your brain and muscle. Some tips for providing nutrition education. First, to check their current knowledge in terms of nutrition. Some residents, when I ask, what do you think healthy eating is? And they think that more vegetable and fruits are good. This is not incorrect, but for older adults, we would like to focus more on protein intake because this is really important for their muscle health. And try to observe their food intake if possible to give individualized education. For example, I observe a resident that he never drink milk. So I just try to tell him that milk is also a good source of protein, and try to drink a cup of milk per day, and work with PSW or food and nutrition assistant because they know the residents very well. They know what they like to eat and dislike. So by working with them, we can provide a more individualized nutrition education for the residents. And some visual aids such as videos and printing materials are good for residents. In terms of knowledge transfer, we also share the results with some healthcare professionals that facilitate the program, so they know the effectiveness of this program. And also we have some residents and their family member also request us to give them their individual results. And because of that, we also have to make an amendment to the ethics committee. And once we get the approval, we will give the individual report for those residents and family members who would like to receive their assessment results. And at the end of this project, we will also work with the knowledge transfer specialists at Pearly Health, and they will also help us to translate these research results into practice so that more long-term care homes can benefit. So now I'm going to briefly talk about the preliminary results of the pilot program that we organized at Pearly Health. So we approached 33 residents during May and September. and 15 of them consented to participate. And we completed the baseline assessment for all of them. And in terms of 12-week assessment, 6 residents already completed the program and the 12-week assessment. And there are 7 residents that are still in the program, and we will complete their 12-week assessment sometimes around Christmas. So today I'm going to share the results based on the 6 residents that complete the 12-week assessment. So the age range from 80 to 100 years old. All of them are males, and they are all recruited from the veterans units. And the mean year of residence in our long-term care home is 2 years. Half of them have a university degree, and most of them are widowed. They have a mean number of 5 diseases with around 10 medications. They are all non-smokers, and some of them drink alcohol in the past 2 weeks. So in terms of cognitive function, the median MMSE score was 27. So for MMSE, 25 to 30 is roughly represent normal cognitive function. For MoCA, 18 to 25 indicates mild cognitive impairment. And cognitive frailty scale is to summarize the overall level of frailty of the residents, and it's a 9-point scale, and 6 indicate moderate frailty and 7 severe frailty. We also measure hand grip strength. It is a very simple and reliable measurement, and it's an indicator to identify those at risk of poor health status. And it is also closely linked to mortality. So the average, the median hand grip strength was 22. In terms of body mass index, they have 26.5, which is considered normal for older adults. We also measure their depressive symptoms using patient health questionnaire. And this is the median score. And the last one is adult social care outcomes toolkit. It helps to determine the impacts of services. It includes 9 questions, which measure social care related quality of life. For example, asking the residents how much control you have over your daily life, and do you think you get adequate food and drink, and do you think you have enough social participation? So the median score that we have is 0.95, which is quite good compared to a study in general population, which find that their score was 0.86. We also measure gait speed and chair stand test and balance, but not all residents are able to complete this task, so I didn't show it here. In terms of compliance, we have quite a good compliance. For exercise, a mean of 66% attend the sections. And for cognitive training, they attend 83% of the sections. The main reasons for not able to attend include they feel unwell, they have medical appointments, they have other recreational activities, or they have family visits. So this is the pre and post results for the 6 residents completing baseline and 12-week assessment. So we can find that for MoCA score, it was significantly improved after the program. And for the other outcome measure, for now, we don't see a significant difference. When we look at the data from the individual level, we find that 5 residents improved their MOCA score, 4 residents improved in their hand grip strength, and 2 residents improved in their depression scale, and 3 maintained their depression scale. And here are the quotes from one of the participants. And he mentions that, I think exercise makes you happier. I know it's strange to say, but I think it does. I have gone through all this information about healthy eating before, but I wouldn't eliminate it from the program. I think the others would probably benefit it greatly. And he also said that, yes, I would recommend this program to other residents because it was both pleasurable and informative. I feel I learned something that I didn't know before. So these are the very preliminary results of the program that we pilot at Pearly Health. In terms of next step, we will roll out the program to non-veterans units here, and we will also carry out the 24-week follow-up assessment to see what's their health changes after the program finish. And we now are able to we also got the funding to support our nutritional intervention. So we will analyze the nutrient intake and offer nutritional snacks and supplements if required. And we will also explore the impact of this program on their loneliness level, because there are many group activities and we think that this will improve their loneliness level. And finally, we will arrange interviews with healthcare professionals, facilitate the program to see what are their barriers and challenges faced when they facilitate the program. So we still have some challenges to solve, like we are difficult to reach residents who do not enjoy group or social activities, and also group activities have to be on hold during the outbreak. And if anyone in the webinar have any insights on how to resolve these challenges, we would be willing to listen. So the key messages of this webinar is that a multidisciplinary program in long-term care homes is feasible. So work with the disciplines in your homes and try to see what fits in their routine and work from there. And it potentially improves the health and well-being of residents. And finally, it is a team effort. With that, I would like to thank you, my team, for their support in this program. And I would also like to thank you all participating residents and all staff members from the video building and also the funding bodies. And here are the references that I use in this webinar for your interest. And this is my contact details. And so that's all, and I would like to take any questions.
Thank you so much, Suey, for all the great work that you're doing at Pearly Health. Implementing interventions in long-term care homes is, in my opinion, extremely important, but also can be quite challenging. And so it's nice to see that you were actually able to implement a multi-component program in a long-term care home. So thank you for that. I'll start with, we already have some questions, so this is great. So the first question Suey is asking, is absenteeism a problem to have these problems successful in long-term care homes?
Is absenteeism a problem to have these programs successful in long-term care homes? I don't know if I understand the question clearly.
maybe I can clarify. I think, Don, that's what you mean, is more like people missing some of the sessions. So is that a challenge when you're doing a program in long-term care? And if I'm misinterpreting the question, please do add to the chat.
Yeah, so as I said, the compliance is not 100%, but actually compared to the literature, especially the exercise class, we have 66% compliance. In the literature, it can be like 40% compliance. There are different reasons for not able to attend the sections, but we will, when we get more data from more residents, we will be able to do like a sensitivity analysis and to really compare those who have high compliance, whether the program is more beneficial compared to those with low compliance.
Thank you. There's another question. I'm curious about the role of therapeutic recreation.
Yeah, so for here, I work with the recreational therapists because they mainly organize the recreational events for the residents, and they know the resident schedule very well. They know whether they are going to the arts program, whether they have the ice cream day or some other activity. So it's good to work with them because they already know what kind of activity interests the residents. It can be a theme or activities that we use in our cognitive training. We also ask the recreational therapists whether there is a location available for our program, because they organize the activities and they know the schedule, whether the room is booked or not. So that's how I work with recreational therapists in this program.
We have thank you, Suey. We have a third question. It's a long one, so thanks, Jeff. Did the design of your research study assume that the individual, so the disciplinary programs, so each component of your programs in physical activity, life enrichment, and nutrition being offered at Pearly Health, was it assumed that they were not evidence based? And then, wait a second, it moved. Pearly Health, we're not evidence and poorly coordinated. What were the reactions of the staff members who managed those programs?
No, I don't mean that the existing program here at Pearly Health are not evidence-based at all. No, that's not what I mean. So at Pearly Health, they already have group exercise. What is new is the cognitive training session. So this is something our research team and the OT team work together and design the cognitive training sections for our residents. And the nutrition part is the dietitian here mainly receive referral when residents have weight loss. But what I also want to focus is that someone who had a stable weight may not have adequate protein intake. They may have a stable weight because they drink juice, they eat butter, that kind of high calorie food that keep their body weight stable. But from the literature, we know that older adults actually require more protein than younger adults. So I want to look at how our residents intake and to see if they are not eating enough protein, then I can refer them to our dietitian and prescribe some high protein snack and supplements to those residents. in terms of coordination, I would say that more coordination would be better. Like if a resident is joining the exercise class already, it would be nice if the physio refer them to also join a cognitive exercise program. In that case, there are more benefits if one resident join multiple programs. And in terms of the reactions of the staff members who manage those programs, I would say well, cognitive training is something new to Pearly Health, so they are very exciting to run the cognitive stimulation therapy. In terms of the physical exercise program, we actually didn't change anything that they are running right now. We think that they are running an exercise program that is already evidence-based with multi-components. In terms of nutrition, the dietitian here are also very engaged in research projects, and he is very willing to consult with the residents in case they are identified as low inadequate protein intake.
And Suey, I misinterpreted the first question. So what they meant was, what are some of the challenges with staff shortages when running this kind of program?
Yeah, there are some challenges. At the beginning, like I said, we proposed 5 sessions a week of group exercise, but it's not really feasible here. So we just work with what's the routine of the physiotherapist team here, and just try to accommodate their working schedule. We also think that in the future, there is a possibility to work with some students in physiotherapy or exercise physiotherapists to work with those students. They can help to need some program as an internship for them, but this will have to be discussed with the university coordinator, and proper training will also be given to students in case they are running this program when there is a shortage of staff.
Thanks, Suey. We have one more question. One of the attendees writes, very interesting presentation. I may be mistaken, but I think at some point you mentioned that the study was with veterans. Was this the intention initially to do the study with a large veteran population? And do you think there would be a difference for veterans, non-veterans participants in the program?
No, that was not an intention to start from veteran units. It was just by random. I started the program at veteran units. And I think that when we include non-veteran participants in the future, we can definitely see if there is any difference. I would say there may be difference in terms of compliance in exercise class. For veterans, I would expect that they are already aware of fitness and discipline because of their military experience. So in non-veterans units, the adherence in terms of exercise program may be lower, but I'm not quite sure. But I will definitely share the results when we have more data.
I think this is it for questions. You do have another comment by Jeff Jutai, and I think that's something that we should definitely consider, Suey. So thanks for your comment, Jeff. Thanks again, Dr. Young, and thank you for everyone for attending this webinar. Also, please join us for our next webinar series scheduled for November 23rd from noon to 1 p.m. by Namrata Bagaria on lifelong learning, seniors junction experiences with Pearly and beyond. Thanks, everyone, and enjoy the rest of your day.